start, please.
Hello and welcome all of you to the Mumbai Kidney Foundation's Education Initiative. I am Dr. Garima Agarwal. I am a consultant nephrologist at Columbia Asia Hospital, Bangalore. Just wanted to check if all of you can hear and see us clearly. If there's any problem, please put a message in the chat box so we are aware of it.
You're audible.
Okay, thank you. So, as you know, Mumbai Kidney Foundation started this initiative to educate and train dialysis technicians across India. Um, I personally very much appreciate this initiative, and all of our dialysis technicians are very keen to learn. In fact, not only them, the nephrologists in the process, revise all their knowledge, and this is a good interactive session with our technicians and ourselves. So at the outset, I want to say that we don't want it to be didactic teaching. Please, all of you, if you have questions, we're going to have enough time for questions at the end of the seminar. The seminar is not going to be very long. It's more about all of you asking us any of the doubts you have regarding this topic. So as you know, today we are discussing two very important topics. One is vaccination in patients and staff, and the other is disinfection in dialysis and other issues related to disinfection in the dialysis unit. Coming to the first topic, there is a mad rush about adult vaccination suddenly, and vaccination is on everyone's mind. But as nephrologists and dialysis technicians, we are, I think, one of those who have been talking about adult vaccination since the very inception. And but the benefit I have to say is with COVID vaccine, nobody argues with me when I say you need to get a vaccine. Earlier, I had to spend a lot of time explaining to them why patients need vaccination, but now everyone's quite health aware. So, as you know, that the chronic kidney population is very immunosuppressed. Their immunity is low and they're very prone to multiple infections, particularly respiratory infections and infections that transmit via blood, like hepatitis. So vaccination is prevents all of those infections. In fact, earlier hepatitis B used to have huge units in the dialysis. There was half of dialysis unit was hepatitis B and hepatitis C. But now with the advent of vaccination, that has been reduced largely. The hepatitis B numbers in the dialysis CKD population are much less. Secondly, hepatitis C is now treatable, so that helps. So without much ado, let me introduce the first speaker, the very, very intelligent and great speaker, Dr. Ajiva Lochna. She's going to be talking today. She is a consultant nephrologist, DM and DNB in nephrology, also an accredited transplant fellow. She's a consultant at the Madras Medical Mission in Chennai. Dr. Ajiva will be talking first about vaccinations in dialysis. As I said, after her talk for about 20 minutes, we will be taking questions. We would like you to ask us questions, or you can just put in your questions in the chat box and I will be addressing them one by one and asking the speaker to elaborate on them. Over to Dr. Ajiva.
Thank you, Garima. Garima is a very enthusiastic nephrologist, and I really thank firstly Dr. Umesh Khanna and the Mumbai Kidney Foundation for giving us this opportunity to exclusively conduct this session in English, actually, for the benefit of people who are not able to follow Hindi completely. Second is to kind of make this a more accessible program to all dialysis technologists. And I think it also extends to the dialysis nurses, who play a very important role, I think, or rather the most important role in a dialysis unit. Now, without much further ado, I'll go on to share my presentation today. I have made it as simple as possible so that only the extremely practical aspects are getting covered. Are you able to see my presentation?
Yes, we are. I think you can put it on. Yeah, we are.
Right. Okay. So coming to the object, so vaccinations in dialysis patients, I'm going to speak about the main vaccinations. Of course, I'm not an expert on the COVID vaccine, so of course, I'm not going to say anything about it. But I think that probably also may be coming into the forefront once it has been completely approved in this set of population. Now, coming to the vaccinations in dialysis patients, the objectives of my talk today would be about the immune system in CKD, the vaccination schedule in adult CKD patients, a little more on the hepatitis B, pneumococcal, as well as the influenza vaccine, and the technique of vaccine administration. Now, coming to the immune system and CKD, the native and adaptive immune system are affected in CKD. Now, what do you mean by the native immune system? This is the immune system which is already present in your body. For example, your skin, cells like the natural killer cells, cells like the dendritic cells. So, essentially, as soon as any sort of organism tries to enter your body, it is stopped at various surfaces. For example, in your nose, you have a mucosal area, you have hair there, which kind of prevents these things from entering your body itself. So you have a large native natural immunity system. Now, what is the adaptive immunity system? This, for just clarification and ease of understanding, is basically your T cells and your B cells. Now, your T cells as well as your B cells basically form the core of your adaptive immune system. So, what happens is once you have been exposed already to a particular organism, or after the organism has kind of escaped all your natural immediate defense systems and entered your body, then what happens is the adaptive immunity takes over. So the T cells are of two types, the CD4 and the CD8. And the CD8 T cells are your killer cells, and they will actually go and kind of attack the cells which are presented to them. Now, they are presented through something called as antigen presenting cells, and once that is done, they get destroyed. Similarly, you have the helper T cells, and as well as basically the memory T cells. They keep a memory of this organism, and once you are re-exposed to the same organism, the B cells will be forming antibodies against these organisms. Are you able to hear me? I'm just getting a notification saying, hello?
Yeah, Dr. Rajiva, we are able to hear you.
Yeah, right. Okay. So in CKD, both the anti-inflammatory as well as the pro-inflammatory cytokines are increased. So there is a complete
I think you have internet issues because you're
kind of the
slowing
whole
down.
immune system goes haywire in CKD. There are many receptors involved in the immune system. Just a second.
Yeah, your video
Sorry.
paused. Yeah, now we can see your screen. You can go on. The voice is in between coming a little slow. I think because of the internet, but it was fine just now.
Yeah, 1 second. Yeah. Okay. Okay, right. Yeah. Can you see it now?
Yes, we can see clearly. It's the voice that was in between. I think when the internet's kind of slow, the voice kind of dulls out. But it's fine now. You can be heard clearly now.
Okay. Right. So there are many receptors which are involved in the immune system, which are again dampened by the uremic toxins. So basically what we have to understand is all dialysis patients have an increased risk of infections. Now, these are your components of the innate immune system, which is your complements, the phagocytes, the natural killer cells, as well as the toll-like receptors. Some of it kind of overlaps and then gets presented to the adaptive immune system, where you have your B cells, the T regulatory cells, the T helper cells, as well as the cytotoxic T cells, which are the CD8 type of cells. This is just for anybody who is interested in a little more in the immunity part of it. Now, one of the most important cause of people dying on dialysis, or the mortality in ESRD patients, is cardiovascular disease. And it is not less than the infection, which actually is really, really high, especially in developing countries like India, where we have a high risk of infections, is in the transplant recipients. So it becomes mandatory for us to try to prevent infections. So it also, and it's kind of like a vicious cycle. The infection also increases the risk of developing cardiac disease. Now, what is our vaccination strategy in terms of in our set of patients? Now, as you know, we have our patients can come from CKD stage 1, which is GFR of around 90 with structural and functional abnormalities, to stage 2 to 3. Most of the times, I think nephrologists tend to see patients above the stage 3 setup. Then some of it in India, as you know, they just come with a creatinine of 20 and they start coming with a creatinine of 22. And that's basically, they have gone into final stages of CKD where they are in need of renal replacement therapy. Then you have the dialysis population, which is both hemodialysis and peritoneal dialysis. And of course, transplant being one of the best options for kidney disease patients. If they are fit for it, it will be what you would ultimately try to do. So at any stage of this whole spectrum, we are trying to prevent infection, and the vaccination strategy should be planned as such. Now, when we are doing the planning for the vaccination strategy, it is important to understand that earlier you do it, it is better, because the earlier stages, the uremia is not much, and the immune response which is elicited from the vaccine will be much, much higher. Now, this is the vaccination schedule, which as dialysis technologists as well as nurses, see, finally the patient is very much in contact and forms a real nice bond with all you people. So it's very important for you to counsel them regarding their vaccination schedule. So one of it is, and one of the most important ones is hepatitis B. I think the disinfection and other part of it will be dealt by Dr. Tyagarajan. So I'm not going to go into details on that. So not HbA positive should receive the hepatitis B vaccine. So what they recommend is we try to give a higher dose in order to elicit a good immune response. As I've already told you, the T cell function in kidney disease patients is very low. So in order for that to kind of overcome that, we are trying to give higher doses. So we generally, for a normal adult patient, we give 20 microgram. Here we give 40 microgram. So if it is available as a 20 microgram, then you can give 2 doses at the same visit, 1 in each deltoid. Then, so basically the vaccination schedule would be at 0, 1, 2, and 6 months. And the other one would be 0, 1, and 6 months. And booster doses, yes, you have to regularly check the anti-HBs titers and accordingly vaccinate. So if the anti-HBs titers are less than 10, it is better to give booster doses. Sometimes it may be necessary to actually repeat the entire vaccination schedule. The other important one, which is often missed, is the pneumococcal vaccine. This is against pneumonia by streptococcal pneumonia. I'll go into detail in this. Basically, the pneumococcal vaccine can be of 2 types, and the booster doses are generally given at the end of 5 years, especially in elderly patients. Next is your influenza vaccine. Now, this is a killed virus vaccine, basically, which is given yearly. So you should remember, influenza vaccine is a yearly vaccine. it should be given around about October, November time, where your risk of influenza is very high. Again, I'll be talking a little more in detail about this. Hepatitis A vaccine is not given on a regular basis to all patients. It's only in high risk patients, like patients with concomitant chronic liver disease, or if they are traveling to any endemic areas with hepatitis A. The vaccine itself is very, very good and elicits a great response in both chronic kidney disease as well as end stage kidney disease patients on dialysis. Now, measles, mumps, and rubella, this is basically even in the older patients, we can give it, but we have to remember it's a live vaccine. So we have to be careful before we kind of give it in patients who are about to undergo a transplant. Essentially, in kids who are have end-stage kidney disease, it is mandatory to vaccinate them. In fact, I think that does not come into the picture because all kids have to be vaccinated against these both MMR as well as polio. Diphtheria and tetanus toxoids are again toxoid vaccines, very safe in dialysis patients also. So the TT vaccine, if needed to be given, can always be given easily. Now, hepatitis B vaccine, to delve a little more into it, all patients with CKD should be vaccinated against hepatitis B. All healthcare workers should be vaccinated against hepatitis B. And it is better to vaccinate in earlier stages of CKD in order to achieve better antibody titers. So this is a small table that I made to tell you how to interpret the serological test for hepatitis B. Now, when you look at the result on your computer or you look at your paper with the results, there are some 3 or 4 tests which are given. Now, some of it will be marked as positive, some of it is marked as negative. Now, how do you consider that what is important and what is not? So when you look at your test, first look at HBsAg, that is HBsAg. Now, if it is negative, that means there is no major acute infection. This is just for the simplicity of the matter that I'm telling you. Now, the next you look at is the anti-HBs. Now, what do you mean by this? These are the antibodies against the surface antigen. Then you have the anti-HBC, that is your core antibody. Many a times when you look at your result, this core antibody will be positive. Many a times I have seen in my hospital, they mark it in red. But before you mark it in red, you have to be very clear in understanding whether this patient is going to transmit hepatitis B or not. And then you have the antibody against the IgG antibody. So IgM is what is produced initially, and IgG is more of a chronic antibody. Now, if all these 4 are negative, it means there is no exposure and the patient is completely naive to hepatitis B, and this patient definitely needs vaccination. Now, if the hepatitis B is negative, your anti-HBs titer is say 500 and your anti-HBC, IgG and IgM are negative, that means you have achieved the best, which is you have vaccinated the patient very well and their risk of infection is very low. But this does not mean you just sit simply on that. You need to monitor the anti-HBs titers on a regular basis and revaccinate if necessary, because in CKD, it has been well established that as years goes by, as time goes by, the antibody levels will drop. Now, if your HBsAg is negative, you have anti-HBs titers and both are negative, and then basically you probably have a previous cleared infection. If your HBsAg is positive, this may be an early infection, or it could be that you have a recent exposure to the vaccine and the HBs titers take some time to develop. However, these patients are a high risk group of patients, so it is better to take adequate and all precautions when you dialyze these patients. So in these patients, only HBsAg is positive and the other 3 tests are negative. Now, if HBsAg is positive and you have IgM and IgG, this is an acute infection. So this patient is of high risk. You need to refer them to a hepatologist in order to look for any signs of liver disease and also treat accordingly. There is treatment for hepatitis B, so that has to be done accordingly. Now, then you have the 6th group of patients where your HBsAg is positive and has only IgG antibody, which means that it is a chronic infection. Again, this set of patients should have adequate precautions when you're dialyzing these patients. The last group of patients where is now HbsAg is negative, but they have only some antibodies floating around. This may be that this is a resolved infection, or it's a low level of a chronic infection, or it's a resolving acute infection. Even these set of patients, you have to wait and repeat the anti-HBs titers after some time and see whether they have developed immunity or not. If the anti-HBs titers are completely negative, it is absolutely mandatory in order to take adequate precautions and dialyze according to a hepatitis B protocol in your dialysis unit. So to summarize this, first, when you look at the test, look at the HbsAg. Is it positive or negative? Now, if it is positive, does the patient have any antibodies or not? And if at all, what are those antibodies? It is anti-HBs and antibodies. Is it IgM or IgG of the core antibody? Now, suppose HbsAg is negative, you have to look at the anti-HBs titers. Now, if your anti-HBs titers is adequate, that means to some extent you're well protected against active hepatitis B. Now, how do you screen these patients? Now, both HbsAg and your anti-HBs is negative. This is an extremely susceptible patient. So a monthly screening with HbsAg is mandatory. Many of us actually do it once in 2 months according to our unit protocol. Now, if you have a good anti-HBs titer of more than 10, then an annual screening and your HbsAg is negative and all your other core antibodies are negative, then an annual screening with anti-HBs is enough. Now, if the anti-HBs is more than 10 and the patient has IgG antibodies, this basically means that this is a prior treated and cleared infection. Though I have written no further testing is required, in our dialysis population, you have to screen every year for the anti-HBs titers. So if it is falling below 10, it is important to either give a booster dose or to actually continue the vaccination. Now, the patient should receive 4 doses of hepatitis B. Now, this is a slight increased dose when compared to us. For example, you and me, that is both the dialysis technologists as well as all of us healthcare workers, we receive 20 microgram, which we give intramuscularly 3 doses. That is, if I receive one today, I receive one in January and another one 6 months later, which is around May or June. But however, in hepatitis, in a CKD population, we give 4 doses. That December, that time I receive 40 micrograms. Then again, I get one in January. Then I again get one in February. And then I again get one in May or June. So this is why we are trying to do this, is to achieve an adequate antibody response. The recombinant hepatitis B vaccine is recommended because it has lesser chance of infection. There is a special formulation, which is Engerix B, which is 40 microgram per ml. Or if you have in your institution, if you have the 20 microgram vial, don't worry, take 2 vials and give one in each deltoid. So intramuscular administration is preferred. The intradermal is not that good. And as I already told you, the schedule should be at 0, 1, 2, and 6 months. Of course, you have to assess the antibody titer. I think it's many of the times the patient says, okay, this is expensive. It's absolutely, it should be a part of your unit protocol, and the patient should not be saying no to this, because it makes a huge difference to the entire disinfection protocol of the dialysis unit, as well as the infection risk, because hepatitis B is highly infective and can spread easily. First titer should be done 1 to 2 months after the primary course, and then after every year. And then the booster doses should be given if the anti-HBs titer falls below 10. Revaccination with the entire regime is recommended for patients who do not develop a protective antibody titer. Now you may ask me, now how many times do we keep repeating this? So maximum 2 times that you can give the entire vaccination schedule. In spite of that, if a particular patient is not achieving the adequate anti-HBs titer, then you have to consider this as a high-risk population and always take adequate precautions, because this means that this patient is not developing immunity against hepatitis B. Now, why are we doing this whole exercise of vaccination? So the prevalence and incidence of hepatitis B vaccinations are very, very high. at almost 7% among dialysis patients in India. A double dose and 4 doses have better seroprotection rate. What do you mean by seroprotection rate? Your development of anti-HBs titers. So up to 90% can be achieved by doing the entire schedule. Now, suppose somebody has gone to their GP and has got a hepatitis B vaccination, but they have got only 3 doses and they have got our usual dose, that is 20 microgram, and now they come for dialysis. Then it is absolutely better to give them the higher dose and do the entire 4 doses. This is a very, and many a times the patient asks, will I get this? Will I get allergic reaction? The recombinant hepatitis B vaccine is extremely safe with minimal side effects, probably a little bit of pain at the deltoid. So it's very important to reassure the patients and make sure that they are vaccinated against hepatitis B. Now, coming to the pneumococcal vaccine, I think the pneumococcal vaccine, to a large extent, probably because of the cost, as Garima may agree, is kind of ignored in many of the dialysis units. It's a very, very important vaccine because it prevents a large amount of pneumonia. As you know, our dialysis patients getting pneumonia most of the times may end up in a death sentence for them. So prevention is always better than cure. So the pneumococcal conjugate vaccine, there are 2 vaccines actually. The pneumococcal conjugate vaccine PCV13, which came later, and the valent pneumococcal polysaccharide vaccine 23, which is your PPSV 23. Now the PPSV 23 came long before the PCV 13. Now it contains 23 polysaccharide variants of the pneumococcal vaccine. Now, the PPSV 23, however, is not that great. It does not give a great immunity response, and it confers no mucosal immunity. That is why the respiratory tract infections with the Streptococcus pneumonia may be there even though you vaccinate against PPSV 23. On the other hand, the pneumococcal conjugate vaccine 13 is actually a conjugated vaccine. Now, this contains 13 polysaccharides which get conjugated with the inactivated diphtheroid toxoid. So, this conjugate is extremely good, extremely immune, and also has mucosal immunity. So, if a patient has never received the pneumococcal vaccine, you have to first give PCV 13. And then with an at least minimum period of 2 months later, that is 8 weeks later, you can vaccinate them with PPSV 23. Now you'll ask me, PCV 13 is so good. Why are you also giving PPSV 23? This is because some of the polysaccharides which are there in 23 is not there in 13. And secondly, there is a larger protection for invasive pneumococcal infections with PPSV 23. All CKD patients above the age of 19 should receive both the vaccines. The PCV 13 followed 8 weeks later by PPSV 23. Now, then PPSV 23 every 5 years. There is no need to give this vaccine before 5 years, and there is no need to test there is no blood test to see whether this vaccine has been efficacious or not. It prevents to a large extent the burden of pneumococcal infections. Now, this is the comparison for anybody who is interested. As I told you, the conjugated polysaccharide vaccine, which is your PCV 13, is basically more immunogenic and better than your PPSV 23. This is because it is actually kind of conjugated along with your diphtheroid toxoid and has a very enhanced response in terms of mucosal immunity. And it also provides a herd effect, that is secondary protection of unvaccinated individuals, which your PPSV 23 does not. Now, how do we vaccinate? Now, if you have never vaccinated the patient for pneumonia, so it's always best to ask the question, have you ever been vaccinated against pneumonia? If yes, please check what vaccine they have received. Now, if they have never been vaccinated, first give a PCV 13, that is generally, sometimes you may hear it as a Prevenar 13. So then administer one dose of PPSV 23 8 weeks later. And then every 5 years, you can give PPSV 23. If previously vaccinated with PPSV 23, that is, somebody has already given PPSV 23, then you have to wait for 1 year till you give your PCV 13. And then after every 5 years, you can redo your PPSV 23. Now, if they have already received 2 doses of PPSV 23 5 years apart, and the last dose was 1 year ago. So basically, the concept here is if your 23 has already been given, then wait for 1 year before you give your 13. Now, if your 13 has been given, after 2 months, you can give your 23, and then after every 5 years, you give 23. So this is for all patients between the age of 19 and 65. Above 65, it is almost the same, but sometimes you can give PCV 13 and then 8 weeks later PPSV 23. And previously vaccinated with PCV 23, that is more than 8 weeks ago, you can give PPSV 23. So sometimes what happens is if they're very old, like 85 years old, and you want to vaccinate, you can just give PPSV 23 alone. So as you look at this, the pneumococcal pneumonia, which is see the basically this what this is showing is with and without pneumococcal pneumonia, what is the death in these patients? So as you can see, if you get pneumococcal pneumonia, your incidence of dying is very, very, very high in this population. So it's very important to vaccinate against pneumonia vaccine. Now, coming to the last one, which is your influenza vaccine. The influenza vaccine should be given annually. So what you have to remember, this is a killed vaccine. Many a times my patients will come and ask, ma'am, can I take this influenza vaccine? I'm going to get a transplant 2 months later. Yes, they can. And secondly, it should be given annually. That is because the influenza virus mutates very often. So that's why the government tries to bring out a new vaccine every year with that particular strain of that year. So that's why every October, November, so the seasonal pneumonia is between September to February probably. And so between October and November, you need to give the vaccine. Now, once you've given the vaccine, you will ask me, when will the patient not get the influenza? So it takes around 2 weeks for them to actually develop antibodies against influenza. So up to 2 weeks, they still have to be careful. This particular vaccine has to be given to the healthcare workers also, especially dealing with the dialysis patients. Because if we get the influenza, there is a high chance we will spread it to them. We will actually have a very mild course and recover from it, but we might end up giving it to them. So it's very important to vaccinate both ourselves as well as the patient. And I think many of the standard hospitals have protocols in place to make sure that their healthcare workers get vaccinated against pneumonia. Household contacts, as I already said, and healthcare workers. So this is also important. The caretaker of the patient also should be advised vaccination to decrease the transmission to high-risk CKD patients. So I am not a pediatric nephrologist, but basically, if it's a very young infant, 6 months to 35 months, you give a smaller dose. If the child is less than 9 years of age, you will have to give 2 doses 1 month apart in order to confer better immunity. After 12 years, this is what most of us are dealing with, that is in adults mainly, you give 0.5 microgram intramuscularly, and it has to be given yearly, and it's basically a seasonal vaccine. The dialysis patients are at an increased risk of influenza-related mortality. There is a 4-fold risk in serum antibody titer against influenza antigens, which have been observed in 50% of the dialysis patients. And they actually don't have a major side effects. Hardly, you may have a bit of, many times there's a main concern with influenza vaccine. Am I going to get fever? Am I going to get the flu? Actually, they may have very, very mild symptoms, but it's actually quite end my presentation, and I'm open to questions.
Hi, Dr. Rajiva. That was really, informative and exhaustive take on all the important vaccines. And we do have a few questions, and then I have my own questions. But I'll start first with the questions from our audience.
Yeah.
So one of the questions which you have already answered in your talk, but I will let you elaborate on this again. So one
Yeah.
of the participants asked that after 4 doses of hepatitis B vaccine, when should we check the titer for a standard patient? Like when do you recommend checking the titer?
So the first time when they are vaccinating a patient against hepatitis B, after the first 2 doses, you can check the titer actually after a month and see if they
Hmm.
are developing the immunity or not. So you have an idea whether this patient is going to develop, because as you know, there is a good 30% chance that this patient may never develop any antibodies against hepatitis B.
Right.
So so after 2 doses, if it's possible, it is nice to check the antibody after a month and see if suppose and you finish the course. Now after the course is over, you check after 1 year. So that anti-HBs titers, if it is less than 10, you need to repeat the schedule. But even after this, if the patient is not responding, it means he is a non-responder and nothing major can be done after that except for taking precautions.
Okay. Okay. Thanks. Another thing was like, I think you mentioned that annual anti-HPS titer should be done. Practically speaking, is this followed in your units or units that you're aware of that they do an immunity? I know that HPS AG is checked very frequently between 1 to 3 months in most centers. But what about the anti-HPS titer? Is it followed as a practice where they are doing it to see the immunity?
So in our unit, we do follow that. We do the anti-HBs titers, and that is probably easily done because it is done in-house. And I do
Okay.
understand many of the centers may not be having an in-house anti-HBs testing. They may have to send it out. But
Right. Right.
it is not very expensive. And I think as a protocol, it would be good for all dialysis units to follow it.
Yeah, I mean, yeah, having said that, but India, everyone has so many different types of, financial models. For example,
Yeah.
in the previous unit where I was at, we had to like really convince the patients, even for HBsAg, they just wouldn't get it done,
Yeah.
even if it's a protocol, because they have to pay for it out of pocket and they just wouldn't get it done. Okay, another question. It's a good question by Jyotsna Kadu. She has asked, can we give the hepatitis B vaccine to an HCV patient?
Yes, you should.
Yeah.
Mhm.
Yeah, so yeah, Jyotsna, we should give it. HCV is a separate disease, and so even if they're suffering from hepatitis C, there's no contraindication to hepatitis B vaccine. And another question the same participant asked, which is also a very relevant question. You did elaborate on it, but I'm going to ask it again. If the patient took a single vaccine, say 4 months back, and now they want to complete their course, then should we do an anti-HPS titer for them, or should we just give them the whole course, or should we give them the remaining course of the next 3 doses?
Good question. This happens
Yeah,
a lot, I think, in
very,
our
very
sector.
much. Yeah.
So I think putting your thought into perspective that it is not that easy to get an anti-HBs titer done, I would probably go ahead and finish the course,
Okay, yeah.
whole course.
So so if they've taken one vaccine, you mean they said 4 months back the doctor gave me one, then you will start from the second dose, you're saying second and then third and then the 6 months back, later
I
dose, or
would
you'll do the
probably
whole
go
course?
ahead and give the entire schedule actually because
That's what we follow.
yeah,
Nobody, yeah, they don't get tested. So we just like say that just forget what happened in the past and we are going to give you a whole new schedule so we
that,
can keep track of it.
yeah.
Yeah, I think that's the way easier way to go about it. Another question that I had that was so a lot of patients feel that vaccination should only be given when the patient is started on dialysis. Do you agree with that? Like should they be vaccinated earlier or is it something which is just to be kept till they start on dialysis or adult vaccination?
Your voice broke in the middle. Can you just repeat the question?
Okay, well, it's a sort of rhetorical question. I know the answer, but I want you to elaborate because you've done it so beautifully. Is that how early in the diagnosis of CKD should we be vaccinating patients?
So I think from an Indian's perspective, when I am seeing the patient itself, if after CKD stage 2, I start vaccinating
Right,
because the immune response is going to be much better once we vaccinate earlier.
right,
So what I would suggest is as a from a nephrology point of view, nephrologist point of view, whenever the patient is seen, try to advise the vaccination because the first time you tell them, nobody listens.
yeah.
Next visit they may listen, and third or fourth visit when you keep on asking have you vaccinated, then they say okay, we will do it.
Correct, absolutely.
Yeah.
Also, what is your experience like? What do you recommend varicella vaccine as a routine protocol for the adults in on dialysis or CKD? Because I know a
Yeah.
few centers in the south which are practicing varicella vaccine as part of their schedule. But do you recommend that?
So we do give the varicella vaccine to our patients, especially the ones we know are going to go for a transplant.
Correct.
And because not everybody agrees, to take it, but who have not ever got chickenpox and are going to go for transplant, we do that.
Okay. So, and is there a gap between when you give varicella and they can go for transplant? Because that's a question I get asked that, oh, I'm due for transplant. Should I get vaccinated or should
Yeah.
I just not?
Yes. So it is a live vaccine. So it is better to give at least 2 months, 8 weeks before you go ahead with the transplant.
Absolutely. Right. So, somebody has asked a question about any knowledge about the newer HBS vaccines or intradermal HBS vaccines. And I
So
know
there are
you,
intradermal preparations which do not, to the best of my knowledge, confer the same amount of immunity as an IM vaccine.
yeah, absolutely. They saw that, yeah, the seroconversion is better with intramuscular as compared to intradermal. So, yeah, better to stick to that for our patients. Now, another question that I had was, it's not, of course, it's to be given IM, and this is a question I get asked by staff. Oh, can we give it IV? Can we give it with dialysis? And like it's no, you can't. You have to give it IM.
IM, yeah.
And another tip to remember: it's better to give on the non-dialysis day because usually on the dialysis day they receive heparin, so there's a tendency they might develop an intramuscular hematoma. I've seen it only once or twice, but so as a protocol in our unit, we recommend that you call the patient on a non-dialysis day for their vaccination schedule and don't give it right after dialysis because of the heparin. Okay, so those were the questions. Even all of my doubts are pretty clarified. Thank you, Dr. Hajiva. We can see if we are ready for the next speaker. Is Dr. Sanjeev? I would give it over to Dr.
Hi,
Sanjeev.
you have two people who've raised hands for questions.
How do I? Okay, I was just looking at the. I was looking at the chat and I didn't see the questions. Okay, I'm gonna ask them to speak now. How do I ask them to ask a question?
You have to unmute.
I ask him for unmute.
Okay, please do that. Yeah.
Before we start, requesting everyone to put their question in the chat box. It'll be faster for the speakers to cover the questions in time.
Absolutely. Would much rather prefer that the questions are in the chat box. But please ask your question. I think you've been unmuted. Okay, I have questions in the chat box that I'm going to ask. So they asked, it's also an important question, Mr. Varun Kumar asked, can we give two vaccines together? So I think he means like, can we give the hepatitis B and pneumococcal and influenza on the same day? Is there a problem with that?
So generally, what we do is give a small gap before we give the two vaccines together in order not to have adequate immunity for both. So generally, if you are giving the influenza vaccine, it would be better to wait for 3 or 4 days before you give the hepatitis B vaccine.
Okay, so and even the pneumococcal, you say that we should always give gaps between these first doses of all of these?
So generally, pneumococcal and influenza, we generally give it together.
Right.
But then the hepatitis B, we wait for 2 or 3 days before we administer it.
Okay. Yeah, that's good to know. Thanks. Anybody else have any questions? Please raise your hands or write the question in the chat box. Okay, Sanjeev. Yeah,
Those raise their hand, now they can unmute themselves and ask the question.
Those of you who have raised your hands, please unmute yourself and ask the question you want to ask. Okay, I think they are not. Then we will hand it over to Dr. Sanjeev for the next session.
Yeah. Thank you, Garima.
Thanks, Dr. Rajivar. What a great topic discussion, and looking forward to many more such. Dr. Sanjeev, over to you.
Thanks, Garima. I am hoping that Bhupen will allow Dr. Tyagarajan to share his slides. We can start from there.
He can do that, sir, now.
Yeah, sure.
All right. So while that is happening, let's sort of move from one aspect of infection control in the dialysis unit to another very important aspect of infection control. As we all know, infections are the most common cause of hospitalization, one of the most common causes for mortality in dialysis patients. And this is obviously multifactorial because most of our patients are immunocompromised, and the dialysis is an extracorporeal therapy. And therefore, disinfection within the dialysis unit becomes a topic of great importance. And that's why almost every association dealing with infection and dialysis have their own guidelines and recommendations for how to go about this. And I don't think there's a better person than Dr. Tyagarajan Tanavan to discuss this. I think he's someone who needs no introduction to this particular audience. He's an old friend, and he's also founder and CEO of Tides Institute of Health and Medical Sciences in Chennai, as well as the chairman for ethical committee in Sri Manakula Vinayagar Medical College Hospital, Pandi. As you can see, he's also multiple other things. So without wasting more time, I'll hand over to Dr. Tyagarajan. Please start, sir.
Thank you very much, sir, for your kind words. Very good morning to everyone. On behalf of dialysis professionals, I thank Mumbai Kidney Foundation, Dr. Umesh Khanna, for giving this opportunity, along with other members. Today's
Tyagarajan, if you could move a little closer to the mic if you're using one, because it's a little less audible now.
Yeah. Today's our discussion will be on disinfections of a dialysis unit. So in this topic, we will be looking into the recognizing the best methodology of disinfections of the dialysis unit, and also we are going to look about the some of the disinfectant for a dialysis unit, how they are going to and also recognizing the signs and symptoms of the infection. Understanding of their actions and ensure the compliance for the infection control measures and everything. So, and also we look into the little bit of an infection control audit and some of the non-compliance and other additional needs and all. So we know right now we are facing with this COVID-19, and as we know that there are many guidelines, especially for the COVID-19, but when we are following the original infection control policy before COVID-19 will be the same for us also, because there is no changes for especially for the dialysis unit, except now we started wearing all the personal protective equipments, and still we are concentrating on other measures for taking care of the dialysis patients and everything. Especially what in dialysis unit, what I always look into the sanitary of the environment standards which we need to follow. Along with that, we have very much concern about the hand hygiene and how we want to do the non-disposable items and how we want to follow the medication preparation area should be there, and the potential infectious waste, how we are going to do the disposals, and how we want to take care of the medical devices. And generally, all our medical devices are highly contaminated because we are dealing with a critical dialysis patients area. When you look into the aspects of infection control, we are very much worried about hepatitis B and how we are screening, and vaccinations has been discussed by doctor. And this education is not only for the dialysis. When you're doing infection control education, so we have to educate even the dialysis patients and attenders also, which will play an important role for the for the prevention of any type of infections in the dialysis units. And most of the time, we are in Indian system, whenever I used to go for infection control audit, I'll be finding very difficult to see the reporting and the tracking of their records. So for that, so most of the time before going to their audit to their hospital, I will ask them to keep all the documents ready, because then only they will start preparing the documents, such a documents are there, because that will help during the audit process of the infection control and all. So most of the time we may do all the works, but we may not document all those works. So that play an important issues in the dialysis. Whenever we go for even for the NABH also, I used to find they may do everything, but there won't be any documentation of those works. Even that is the most important thing which we need to follow in our system. So like in infection control, there is some of the questions we used to ask, they used to ask in a facility and isolation room, may they refuse to accept the hepatitis B positive patients, so that the isolation room can be used for regular station and used for all shifts. Sometimes the positive patients in India, around 30% of the hospital, they never go for positive patients in their dialysis unit. They do only negative cases in their hospital. But sometimes this is the most important thing. We can't able to denial of any hepatitis B positive patients coming to our hospital also. We can't able to say no for them in case if such cases are coming in emergency situation. But only one consideration I always think, if it is a positive or whether if the patient is a negative, we have to consider all dialysis patients as a positive. This will help us to maintain the quality systems, how to maintain the universal precautions and everything. Whenever you consider this is negative, we can touch the blood, we can see, you can have a food there, you can have everything, the meetings and no. You have to consider what is the universal precaution for positive room. Same dedicated precaution you have to take it for the negative also. So in that way, you have to say, suppose if there is no patient at all, no worries at all. So you can take the negative patient, disinfect the machine properly, especially the body of the machine needs to be disinfected. So only one thing, if it is a patients are going to come routinely in your dialysis unit for a positive cases, you isolate and keep a dedicated machine for that. Because sometimes you may get a regular patients or weekly twice patient, only one patient will be there. So for that one patient, you have to isolate one machine. Means if you are going to isolate, it is better to isolate and keep it separate for that, because this will allow you to understand where you are, how you are processing the system and everything. And most of the time, the supplies of isolation rooms where you are going to keep it separately, that you have to keep it segregate and everything. But one thing is, consider that you have to follow universal precaution for both the negative and positive. But I don't think the machine become used for positive, it's always the machine is positive. You can disinfect and you can use it for the negative also. Only thing is the body of the machine needs to be clean. So that's a major important thing you have to look it into the disinfecting of the machines and area. And infections that patients can get from hemodialysis. So patients who undergoes hemodialysis generally have a higher risk of infection due to the, they may using the catheters and even AV fistula needle, and even they are in a weakened immune system. And they maybe have a frequent hospital stay. Most of the time they come to the hospital and surgeries will be going on for them. So they are high risk of, these people are dialysis patients are high risk people. And they are more prone for getting any type of infection, especially the hepatitis B and C infections and other bloodstream infections also. So in one of the hospital, I remember we were doing a clinical auditing for the hospital for the, every month they used to get up 1 or 2 patients of a positive in a hepatitis C cases, which is like almost within a 6 month of a period of a time, there are more than 10 patients converted into positive to the negative to the positive of hepatitis C. So when we were doing auditing for that particular group of hospital, we understood what is the reason for the infection. It is the infection, there are multiple areas, the infections, but we found that the patient getting dialysis not only in that hospital, he will go to the outside hospital, he will take dialysis also. So in your hospital, if your dedicated systems are there, you have to identify whenever the dialysis patients are skipping the dialysis in your hospital. If your dialysis patients are skipping the dialysis and coming after a 1 or 2 dialysis, after a 2 dialysis, they are not coming, then again coming. So you have to identify whether they took the dialysis outside or not. So most of the time, patients are not give the information to the dialysis people, staffs, because if we say anything, immediately we'll ask them to go for a test. So if you say ask for a go for a test, another some few thousands of rupees may be spent by the patient. So they don't want to spend that money. So due to that reason, they most of the time they will hide where they are going, for what purpose they are, whether they will say I'm not done dialysis for more than 10 days. So I went for many reasons they may say, because the person who were there for a long time for without dialysis and were in a chronic situation suddenly come to the dialysis, he may need to do some works, he needs to go out and everything. So only thing is consideration is we have to tell them very clearly, and also because these people can't able to understand, especially the people who are having a uneducated people, they can't able to understand. So we have to tell them what is the reason for them not to go outside and take dialysis. So in the beginning of the dialysis, the patient need to be clearly explained, including the attender, why they should not go to the outside hospital for dialysis. And if they are going for outside hospital for dialysis, then you should have a clear communication between your hospital and that hospital, how you are going to give the reports to them to go and take the hospital in another hospital, where they are also going to do it in a negative machine and very carefully, and they are going to send it back to the same hospital back. So in that case, you don't want to do any type of a testing. So you tell them, teach them properly, and get associated between the hospital among your cities and everywhere, because it helps him to give him a support. And they need to have a you should have a support them how we used to face the problems. So if you do in such a way, they will be more happy to tell most of the truth in dialysis, among whatever they want to tell to you. They will give the opinion, or at least they will ask some suggestions for that. So that much of a confident you have to associate with the dialysis patient, and the attenders need to tell all the each and every plan for going out for taking dialysis. Due to many reasons, they may go out of the city and go for other place for some other works and everything. So you have to make them very clear about this thing. And most important thing is, the patient never, during the conversation, they never listen. Sometimes you have to prepare a small few terms and everything, 1, 2, 3, 4, 5 points, and then tell them these are the things you have to follow, and then sign the paper or get a sign from the patients and patient attendants. This will help them. Okay, we have signed regarding these things, and all. We have to inform them that we are going outside of the hospital. So this will help you to reduce the infection in the dialysis. So at the end of the audit, we came to know the patient never tell any information to the dialysis tech or to the nephrologist. They will just skip the dialysis, go outside, finish their work, get dialysis there, and come back to the main city. So this is because of there is no association, there is no relationship between the dialysis patients and the tech. So that relationship should be that should be a right important information. You should make your good contacts with the patients about the confident and telling about the infection issues and everything. Most important thing you have. There are 1 in 4 patients who get the bloodstream infection, and there are the causes. The bloodstream infections causes sepsis, and the death is increasing. And up to 1 in 5 patients with an infection die within 12 weeks also. So we have to be very careful, and we know very well now what are the mode of transmission of the infections. Now the contact, droplet, and airborne, that we are clearly seeing during this COVID-19, and how we are protecting. And during this period, the dialysis professionals I'm seeing from the past 9 months, they are corona warriors, and they are during this period, they are given their full effort to take care of their patients and everything. It's really a great work by the dialysis professionals. And it's a mode of anything. It's a bacteria, virus, and it is a suspectable way, what mode of a transmission and everything. So we have seen that how we are contact of this transmission. spread, and the healthcare workers, and now they are, still whatever I see from the previously, now the infection control they follows stringently for the protection and everything. And the spread, now the respiratory infections is very clear during this COVID time, and it is a droplet transmission, and tuberculosis spread by this airborne transmission also. So we have to be very careful in the spread of infections. So what can we do to prevent the spread of infections? So as we know that we are following the standard precautions, all healthcare workers are expected to follow the infection control policies, and we have the guidelines to follow. And it needs to be continued forever. Whatever we wear the mask. Earlier, we never used to, many hospitals I have seen the mask and the precautions, whatever they take, it was less than compared to the before COVID. And after COVID, during this COVID and during this COVID time itself, I can see that the care and the precautions and the personal protective equipments are. This is going to help us, to bring out a better quality outcome for the dialysis patients and also for the staffs also, because most of the dialysis staffs are getting infected because of not following the standard precautions and everything. So now it is going to help a lot because of the stringent policy, and everyone understood how much this infection is going to cause a complication to the public. So all the standard precautions, the healthcare workers in all settings, hemodialysis settings, and we have started with the proper hand hygienic techniques and PPE and all the safe injection practice and everything. So once we follow the hand hygiene, so we are very clear, even whichever the base, whether it is soap or alcohol based, it is perfectly great. And wearing the gloves and a face mask and maintaining the system, it's really fantastic what I saw previously. Comparatively now, it's really interesting. And the specific infection control, it's a recommendation for the outpatient hemodialysis healthcare workers. So as we saw that we are looking like wearing the gloves and other personal protective equipments for all patients, and also the vascular access safety that we are looking at taking care very perfectly, and separate the clean area from the contaminated area, and use the medication vials safely, and clean and disinfect the dialysis station between the patient, and perform the safe handling of the dialysis. So when we are separating the clean area from the contaminated area, so we need to know which area is a clean area, and how we are going to disinfect those areas, and what are the things we need to store during those supply requirements and unused supplies, how we need to segregate, what are the consumables we need to take to the patients while doing the procedures, and how we want to, sometimes people takes a lot of things whenever the patients are struggling, for a fistula problem. So we have to understand, if the fistula cases, if you are taking, we should know that by 1 hour maximum, with the one prick itself, we should get the vessel and we should cannulate the cases. If it is a long time or something problem with the issues, better we have to go with the catheters and everything, or immediately change what are the requirement to get a good blood flow from the access. So, and most of the time, blood samples are sometimes, so most of the time after blood samples only we used to start write the names and everything. But you have to be very clear that you should take all the, whatever the samples we are going to take, the vials needs to be prepared before that, then the samples needs to be taken. And whenever the blood samples are taken, and we need to keep a separate area, and you should have a separate handle to handle all these vials and everything. So you should have a multiple container to have, how you are collecting and sampling all these blood samples and everything. So you have to maintain the treatment stations like a, or a contaminated area, which area is not contaminated, that you should be very clear. And most of the time, these vials are moved into the writing area, documentation area, also the blood sample will be moved. So you have to be very clear. Sample, once if you finished writing the names and identification of the sample, then the sample needs to be collected. And once you collect it, it should be segregated in a right place for a storage for the movement to the laboratories. So dedicated supply to any single patient. So these are the items that needs to be taken to the patient. That supplies only need to be taken. and getting the reverse back and everything. Sometimes in our dialysis unit, only the most important medication, the heparin, which may sometimes used for a 2 to 3 patients also, one vial, because of like a 20,000 units of heparin. But one important thing we have to consider is that is even in some hospital, I given a protocol. Even heparin will be preloaded and kept it isolated, and it will be with a proper dosage with a normal syringe. Say it is a 20 ml syringe. It will be preloaded and kept it, and only the syringe will be taken from that particular segregated syringes. So rather than loading that thing in front of the patients with the gloves and everything, it will be preloaded by one particular person, and it will be identification with the what is the dose of that syringe. Each syringe, maybe it may be a 20 ml syringe, so it will be loaded in such a way for a proper usage of the heparin also. Because sometimes loading in front of the patient or taking the sample more quantity of heparin also sometimes, because whenever you used to load the heparin, I've seen many times if you want to take a like a 1.5 ml from one vial, say it's a 5 ml vial, if every person start to load it, by the time when the third fellow will come and see the sample, it will be only 1 ml. Because the reason behind this, some extra amount of heparin has been taken. So heparin, we have to be very careful handling. So why? Because this is an important area where the infections will cross over from one. Even sometimes heparin need to be increase the load. So we may use some vial. So if you are using that vial, it should be again sterile. If you are going to reload the heparin for that same patient, it should be very careful. Otherwise, infections will be more common over there also. And medication vials, especially some medications are multiple dosing. So that clean area, you have to keep it, and don't carry the medication from station to stations and store the medication. So if you're still carrying, so that disinfection we need to follow how to follow. We'll look it into those things. So guidelines for carrying the medications, like don't use the same medication cart to deliver the medication to the multiple patients, or don't carry the medication vials and syringes, alcohol, swabs, and supplies. And sometimes it will be in a pocket. Sometimes the people used to keep all their vials in their pockets itself, because suddenly in case of requirements, they used to take the vial from their pockets, and that causes infections, especially in the dialysis units. So be sure to prepare the medication in a clean area away from the patient station and bring it to the patient station for that patient only at a time of use. So most important thing in our disinfection is environmental contamination. This is the most complicated. The patients with the pathogens such as MRSA, which is methicillin-resistant Staphylococcus aureus, and the Clostridium-resistant and vancomycin-resistant Enterococcus, and other Acetominobacteria were frequently contaminated environmental surface in their immediate environment. These organisms can remain viable in the environment for weeks or months. So that is why most of the time the dialysis go for fumigations and everything. So examples of a contaminated environmental surface in our dialysis unit, you can see looks like a bed rails and and bed linens, overbed tables, and blood pressures and cuffs. And if you have intravenous pumps and nurses call button and the urinary collection bags. So these are highly, contaminated near to the patient. This will be a near to the patient contaminated area. So what is the this article says that does the increasing the cleaning and disinfecting help reduce the transmission of the pathogens? So it is true. How many times you are disinfecting the floors and how many times you are disinfecting the pots and beds, that play an important role for the reducing infections and pathogens to the patient. So how you are going to do, what you are going to do, every patient, between starting every patient that needs to be cleaned properly. And when you're looking into the level of disinfections and cleaning required for patient care equipment, so there is a classification we used to say named critical and semi-critical and non-critical. When it is a critical area, the applications will be like a entry or penetrations into the sterile tissues, a cavity or a bloodstream. And it is a sterile, germ of required at the level of germ cell actions required sterilization. And semi-critical, like a mucous membrane and non-intact skin, high level of infections, and non-critical contact with the intact skin and low level of infection. But we are using a higher end of area of a critical area where our, the whole, the blood has been taken for a purification and everything. So these areas you have to be remembered. You have to think you are taken out the blood and you are, you are dialyzing the patient. So you have to be very careful. We are in a very critical area, and you have to think how much the infection spreads in your dialysis unit. So that much careful you have to say you are equivalent to the ICU or you are equivalent to in the operation theaters. So the non-critical items like patient's care, like a bed fans, blood pressure cuffs and pressures, and also the computers and other non-critical environmental surface like a bed rails, bedside and over bed tables and what is called furniture in patient's rooms and floors. So these are the non-critical items. Coming to the other, what are the common agents used for doing this environmental survey? So we have a different group of population and a different group of tier 1 to tier 3 cities are there, and depending upon the hospital. So most of them are prefer for the sodium hypochlorite for cleaning. So that percentage you have to follow, and it should be cleaned properly. And other thing like cleaning other things like ethyl and isopropyl alcohols and other germicidal like you have ammonium germicidal and phenolic germicidal, or Indophor is one of the best germicidal, and the other is the accelerated hydrogen peroxide solutions are used. In the coming to the in the like a sodium hypochlorite, what is the percentage and dilution level? It depends upon what type of area you are going to be activated in this. So most of the time, when it's like a 1:10 dilution of a household bleach, that is a sodium hypochlorite. So active against the C. difficile spores and everything. So most of the time we always do with the 1:10. Other, which is a very, very less of 1:50 dilutions and everything, but better always go with the 1:10 dilutions for a better outcome for the results and everything. In the other cleaning and disinfection, the cleaning and disinfection reduce the risk of spreading of the infection. The cleaning is done under the cleaning detergents, water and frictions, and it is intended to remove the blood and blood fluids and other contaminants from the objects and surface. The disinfection is a procedure that kills many of remaining infection causes, germs on clean objects and surface. So for every procedure, even if it is a blood spill over the floor and all, you have to be activated immediately without taking much time. And most of the time in our dialysis unit, we can still see that even some blood stains during the audit, I have seen, it will be there in the wall for a long time, many days, and many days it will be on the floor also, and many days it will be on the machines, especially on the bottom of the where we used to keep a dialysate and everything. So all this needs to be clean. Even sometimes the blood will become dry and it will become more than a month also, but it may not, they won't remove those things. So better, we should not see any blood stain in the dialysis machine or in the wall, the wall or on the floor. We should not see all those things. So you have to be very careful on the blood stains and everything. So every time all the dialysis equipments and surface are contaminated after the dialysis session, and therefore must be disinfected immediately. After patients leaving their station, they disinfect the dialysis station, chair trays and the countertops and machines for after each patient's treatment. So wipe all the surface. Surface should be wet with the disinfectant and allowed to be air dry, and give a special attention to cleaning the control panels on the dialysis machine and the other commonly touched surface. And empty and disinfect all surface of the prime waste containers and everything. So it should be done between each and every patients to prevent the, especially to prevent the infections in the dialysis units. So the water and dialysis quality, when you look into the water and dialysis quality, we always think most of the time, so now your environmental of a dialysis unit is clean. Whichever the chemical you use, you should know that frequency of those chemicals and usage and everything. When it comes to the water treatment, during the last few audits in the water treatment, I understood the water getting contaminated not only for the dialysis unit, even it is getting contaminated for the whole hospitals also. So when I used to do audit for the water treatment, I never see only for the department dialysis unit. I will used to review the whole hospital also to see where is the contamination is happening. Because once you are preventing the main water system from the hospital, we can't able to control the water system issue in your dialysis unit. So first it should be prevented and controlled in the whole hospital. then you have to go back to your dialysis unit and control. It will be very easy also, because rather than spending the dialysis unit water quality issues, first you have to treat your water quality in your hospital. So what type of a tank they are using, what type of a check they are using, because in Indian scenario, we may get a metro water or sometimes we get a groundwater, and most of these waters are always chlorinated. This is a normal protocol in most of the hospital to chlorinate the water. Once you chlorinate the water, what is happening? The issues you are facing here is your all your carbon charcoals will not work after a time due to the high chlorine issues, and then it will damage your membrane. And you can see the organism growing pre and post RO also. This is the major issue we are facing across the Indian situation because of the contamination, because of the chlorines are not controlled properly. And once it is not controlled, the organism will goes into the all the system, not only your RO plant, not only in your tank, post RO tank, it will goes to the complete looping of your system and form a biofilm for a longer period of a time. And slowly it will start generating the organisms, and it will enter into the, complicate the report. That is a report of whether what is the colony forming unit of your water, or for a machine, or for your looping, or for your tank, or for your post RO plant. You will be getting the high concentration of a colony forming unit, and also you will be getting a more amount of endotoxin levels also. So that needs to be stopped. Means you should know the understand of what is the between the how the chlorine needs to be dechlorinated. So those things you have to understand. So now we got a regular, how many times of the frequency of the tank cleaning, that also we need to look into the disinfecting of them. So most of the people think that cleaning only with the sodium hypochlorite, just cleaning the tank and the loop, its job is over. But generally sodium hypochlorite is not generally effective for cleaning the loops and the tank. So that makes a lot of complications of the system, eroding the pipes, and this may complicate further to the long-term usage, because in our dialysis unit, we think once we set up the dialysis unit, our looping, everything is completed. This will be the last for a many years, and even for a 30, 40 years, they never change the looping at all. Once the, every looping had their age, but if you maintain properly, this looping will come for many years also. But how we need to handle it, that you should know what is your feed water problem. You want to understand how the feed water level of conductivity is there. Most of the time, what is the TDS level we are looking, what is the conductivity level we need to look, it's a query. Most of the conductivity in Indian scenario, it's very, very high for the dialysis machines and everything. So we have to understand what level we are achieving, because in none of the books or in none of the international guidelines, it is not mentioned how much conductivity should be there, how much TDS is there. But after reviewing the multiple documents across the world and pull out all their data and everything, then I identified what is the standard used in the Australian community, what is the standard used in the Japanese community, what is the standard they use in Chinese community, what is the standard in the England or in United Nations and in the US. So everyone have their own different standard, and none of them are not documented in any of their books. So after collecting many data, what should be the conductivity, what should be the TDS, then we understood the conductivity should not be more than 25 and TDS should not be more than a 15. This is a reports, stringent report collected from the multiple countries from their quality data. So why I want to talk about this TDS in the disinfection is based on your methodology for chlorinating properly and dechlorinating the system, then only your membranes will work. Once if your membranes are functioning properly, then only your infection will be very less or your growth will be very less in your tank. How the growth will be very less? How you are going to clean the tank? Are you going to clean the tank with a proper parastic acid solution? That will make the value for the improvements in the loops and the disinfection of the loops and the tank. And coming to the in-depth about cleaning of the tank, we'll see, and mixing system and monitoring and adverse event, what we are going to face. Because most of the time, the disinfectant of the water treatment system, it is like what is the percentage we want to take it. It is like we have to understand what is the length of the loop, what is the diameter of your loop, and how many length, that's total. If you give the thing, that will be the volume of your complete loop along with the volume of your tank. So these things need to be measured before giving your disinfection concentration in your tank. And then once if you calculate all those things, you will be able to understand how to disinfect the loops and the tank. And also now it has come with the ozone disinfectant also. Ozone disinfections of the loops and the tank also it is nowadays done. And reverse osmosis membrane. Most of the time people think if I disinfect the, if my pre and post are contaminated, I have to disinfect the RO membrane. It's not going to do very well because the already it's a pre is having and post. If you see the pre and post of TDS, the pre may be a TDS of conductivity say around like a 300, and post will be around like a 150 conductivity. You feel that what is happening? That means your membrane is already ruptured by, and sometimes most of the time your output will be going very low because of the scaling of the membranes and everything. So no one will guarantee you how many months the membrane will function. The reason behind is they are very much not assured about your chlorine level in your water, because sure that is going to damage the membrane. So that is the reason none of the company will give you the assurity for your RO membrane. So for that, what is the thing? Anyhow, what is their opportunity is they may sell more membrane to you. What is your issue will be how many times I will be changing the membrane without out. What is the problem? There is a problem of a chlorine in your water. So that needs to be prevented. That prevention need to be preventive action to be taken. Then only if you do a proper disinfectant of your tank and loop monthly once or 2 months once, that will be fine for you. But ultimately, you have to invest for the good RO membrane, but it will not come output because your water quality is not maintained, your chlorine level is very high, and that damages the membrane. Finally, ultimately, you will be spending a lot of money for the water treatment, and you will, it's like a hidden cost. No one knows how much you have investing for the water treatment. So that much issue will be faced because the system is not clear and how you are going to disinfect the loops and the tank. So once if you are done, your biofilm will never form. You will not get any type of infections or any type of a growth in your system, in your RO plant, or because if you check a one sample in your post RO tank, that is more than enough. It's nothing to do worry with the checking in the all the machines. Machine will not generate any organism. If you are disinfecting the machine with a proper cold disinfectant, it's with a proper parasitic acid disinfectant or something, that is going to be effective forever. So that you need to be keep it in our mind. Proper disinfection is the most important thing of your hemodialysis machines and the tank and the loops. So it's not a purpose of disinfecting the membranes and all. Membrane disinfection, it doesn't going to make a big help for you. So you have to do the preventive action of how to reduce your chlorine level less than 0.1 0.1 ppm in your, that means it should be a milligram per deciliter, that should be brought it down. So in type of aldehyde chlorine organic acid for cleaning the hemodialysis machine, it is always I prefer of parasitic acid disinfecting of your cleaning of your hydraulics and everything. And it is a strong, it's the advantage when you compare with the aldehyde and chlorine and organic, either it is a citric acid or something. So it is better to go with the parasitic acid or citric acid, which is a better compared to the other chlorines and all. Because sometimes the people think I can keep a chlorine, sodium hypochlorite monthly once or 2 months once. It's not required at all. If you do a proper descaling, is more than enough for your machine compared to keeping the sodium hypochlorite for some other reasons. But simple parasitic acid will be more helpful because chlorine, it should be properly diluted and properly it should be there. So that's one important thing which I want to tell in this. And the use of hemodialyzer and blood tubing, which is the most important thing. So my understanding of disinfecting of hemodialyzer and blood tubing is, first thing is you should prime the blood tubing at the flow rate of 100 to 150 ml. Why for disinfection, why I want to discuss about priming is, if you do the priming exactly with 100 to 150 ml, so there won't be any air in the dialyzer. That will help you to reduce the clot and that will help you to reduce the infections in the diabetes. What will happen if there is a blood stain in your membrane? There is a blood stain in your membrane. So what is going to happen? That stain will be there forever. Where it is, you are going to disinfect the membrane, that blood stain will be there with a contaminated parasitic acid or formaldehyde. But ultimately, there will be a contact of those membranes again. So please kindly do the priming at the speed of 100 to 150 ml, which will help you. And a proper disinfection method, better please go with a parasitic acid disinfection as early as possible. Think about a long-term quality outcome of your patients and everything. And coming to the policies and practice, for the infection control policy practice like outpatients, hemodialysis facility. So already you saw the vaccination in the dialysis unit and how to prevent the spread of hepatitis B and preventing the spread of bacterial infections and everything. So in that, most important thing, already you saw the vaccine. And especially for the spread of infections, B and all, the room disinfection. So you always think about a room disinfection is done weekly once on Sunday. With the help of OT care equipments, containing the incidure. The duration of exposure is approximately 1 hour, and the doors are opened afterwards. So incidure is the better, there is a availabilities of incidure or other germicide you are appropriate, you can use it. And sometime I used to go for a ozone disinfection of the dialysis unit, which will be connecting at the rate of a handle ozone for some of the hospitals, and which will be a room disinfectant also for a better, it is a handy like that. We worked on that area also. So that is an interesting chapter of ozone disinfection of the room. Floor disinfection, it's basically it should disinfect after each and every shift. So we should know from first shift to the second shift changing, the floor need to be disinfected immediately. And this is done to start with the swabbing using the wet swab. So antiseptic lotion, whatever you are using in your units, that should be very clearly specified. And what about your floorings and what type of chemicals will be used? It can be used routinely. And emission disinfections, which is a heat disinfection or chemical heat disinfection, or with a cold disinfection, you can use it, should be done between the shift and each of the day, at least in a day once. The parasitic acid disinfection also will be work out very well. And it's a recap, the preventing infection in hemodialysis setting. So the key infection prevention practice is always perform the hand hygiene frequently and change the gloves, and maintain a separate clean area for supplies and medication, and separate the contaminated area for unused items, and practice a proper handling and delivery of the patient supplies and medication. Perform effective cleaning and disinfection of the dialysis equipments and environmental surface, and careful handle the medication and patient's vascular access to avoid contamination, and use the aseptic technique every time. So in conclusion, infections that patients can get while receiving dialysis, serious and preventable. It's healthcare workers like you are following the infection control precautions and other safe care practice are the key to the prevention. So infection prevention is everyone's responsibility. Thank you very much.
Thank you, Dr. Tyagarajan, for that extensive talk. There are quite a few questions, but I'd like to start with the first one that was asked. Some of the questions are circulating around the hepatitis B, C thing, which we will come to. But the first question that was asked was about the endotoxin test for the water used in dialysis. So the thing here is, as far as I know, the Army guidelines for endotoxin testing was changed in 2011, and the guidelines were made stricter. And for dialysis, for dialysate, it was 0.5, less than 0.5 EU, and for dialysis water was 0.25. But if you're using ultra pure water, it was less than 0.03. But I don't think there was any recommendation for how frequently it needs to be tested.
Yeah.
And I think it just said regular. I don't remember if there was any specific recommendation.
Actually, yes, sir. Actually, looking into the standards as per the AMI standards, which we follow for the endotoxin level, we generally keep it as a less than a 2 for AMI standards, but still, as per the pure water for the endotoxin level, as we're seeing the screens, less than a 0.25, and for ultra pure water, it is for the 0.03, which is a replacement fluid for the patients, like especially on the high flexing. Yeah. So when we were looking into the ISO standard, it was most stringent. It is 0.025. Which we want to go ahead with it. But what is the recommendation by the NABH for a hospital? They for dialysis in one of the places they mentioned monthly they should do the endotoxin level. So that made into a big critical issue. Even I wrote because I'm in the one of the QCI board, Quality Council of India. So I wrote a mail to the government and also to the NABH association saying that it is not possible to do a monthly test. And most of the thing in Indian scenario, the test samples are taken from the hospital and goes to the outside of the hospital. Actually, endotoxin level should be done on the same spot itself. Then only we will get a report. That is called on-site testing of endotoxin. But in India, all samples are taken out and the report will be showing as a negative or less than 1 also. Which is the not at all. It's not going to be a. It's what has a problem here is still NABH doesn't know this point also whether it should be done on-site testing because there is no guidelines for that. Whether it should be done online or should be taken to the off-site of they can do the sample. But I told them not to go for endotoxin level. Check for the colony forming unit, which can be done in their lab itself. And endotoxin doesn't going to make a big changes because all our membranes are endotoxin retention. If that hospital having an online HTF or they are having a high flex membrane, then you can go for it. So this recommendation has been given, but still it is under the review by the NABH. But it is not going to help at all also endotoxin level for every month, which is a cost.
And it's not cost effective also.
Yeah, it's not a cost effective. Yes, sir. And yes, sir. Right.
Moving on, the next question was about this. There's a bunch of questions that surround this, so I think we'll take them together. So the question of hepatitis B patient who has received treatment and become negative, and hepatitis C patients who've received treatment and become negative. I think we have to deal with these two separately because Hep C and Hep B are now completely different. Hepatitis C, because of the new DAA regimens that are available, seroconversion is now almost the norm. And in any ways, the guidelines don't actually recommend separating hepatitis C patients. So if you have a hepatitis C patient, you treat them and they are having sustained viral remission, you can convert them back into the negative side. I don't know if how many units are still separating hepatitis C patients. We are in our unit. Hepatitis B is a much more difficult scenario. I have one of these patients that Pradeep has asked about, described here quite clearly, which is a hepatitis B patient who has received treatment and has become negative with undetectable viral load. Now, we have exactly this kind of patient in my unit, and we've had a lot of discussions with other nephrologists, with the gastroenterologists. The gastroenterologists are saying, treat them as Hep B negative and put them in the negative side. But not a single nephrologist has agreed that they can be taken up on the negative side, because the problem is if there is some undetectable inactive virus which can become active at some point later on, then you risk contaminating the entire unit. So that is the risk with hepatitis B. To the best of my knowledge, I'd like to hear if there is anyone else who has a different take. What about you, Tyagarajan? What do you think?
Yes, sir. Actually, in this scenario, what I always used to consider is I'll consider all negative patients also positive only, because most of the time we don't know who is having the active infections and everything, or a chronic infections which may not be detected both in the HBsAg or even for the HCV. Still, they go for a very low level of testing equipments for doing the hepatitis C virus also. Even if those patients converted into a negative again. So generally, it is like coming to the dialysis unit, whether it is a positive rooms or negative room, putting a one screen is enough means then we have to put a screen for all the dialysis patient or segregating the patient. So only thing is the dialysis staff need to be very much careful, and they should be have a competent that they should treat all patients as a positive and handle the from one patient to another patient. They should do the hand washing and they should do the scrubbing and then touch the machines and everything. If they follow this thing, we don't have any problem of segregating the patients or anything. But there is a question whether our people will have the competency to look into the thing. So those competency should be trained by all the in charges to all the junior level incoming new staffs and everything, and should be monitored, strictly monitored. Are they doing all the procedures perfectly or not? Otherwise, no issues at all for me. And I will always recommend you can put all patients together also. Only thing is they have to follow the universal precautions. That was my only idea from my end.
Right. Okay. So there's this question. I think you've covered this in your talk, but anyway, since it's been asked again, you can talk about it.
Sure.
To use peracetic acid rather than citric acid, is it safe to use peracetic acid for disinfection of tanks and loops and the machine? And do we need to check any level after the disinfection?
Actually, when we are looking into the disinfection with a cold sterilant, we can use it for the hemodialysis machines also, because when comparatively using with the citric acid, hot disinfection, because this citric acid will be effective during the hot, compared to the peracetic is a cold disinfection. And it's going to be helpful for the machine only, especially the scaling of the machine, especially iron rusting. You can see the change in the color in the dialysate line, which will be effective in this peracetic acid. Coming to the tank and everything, most of the time we used to do a disinfection, says with a sodium hypochlorite and all. Instead of a sodium hypochlorite, finding the level, cleaning the system and the loop. So this will not be effective for the biofilm formations and all. So biofilm, if you want to remove with the sodium hypochlorite, it is not going to help also, because the people who have the loops and all will be more than 10 to 20 years also, will be using the same loops. So for those type of loops, it's better to go with a peracetic acid and nothing going to be eroded, because only thing is what type of a material they are using. Nowadays, whatever they used previously, the material they need to identify, because all the materials, they are very clearly mentioned what type of material they have to use it for the distribution of these lines and everything. And coming to the not only peracetic acid, it can be disinfecting with the ozones also we can do. But peracetic acid is one of the international standards are there only for the peracetic acid. Nowhere else it is documented for the formaldehyde or a sodium hypochlorite. There is no documentation for that, because internationally all guidelines says about peracetic acid only. But in India, due to the non-availability of a few years or 10 years before it, there is no non-availability of peracetic acid. Now it is available, so it can be used and it can have a better outcome for the dialysis patient, better quality for the dialysis unit also.
Right. Okay. There is, I think, Jayesh Yadav has a question about using treated water storage for hepatitis B, C, and negative, and whether one is better than the other for machine disinfection, hot or cold. Do you want to take that?
What is the meaning of the? I can't able to get the point, sir. Can you able to repeat the question?
For machine disinfection, which do you prefer, hot water or cold? And whether treated water storage? No, I'm not able to understand the first half of the question. Let's see. Maybe we should allow him to directly ask his question, because I'm not sure what the first part of that question is.
So, what is the plan is like most of the hospital, if I'm right, means from the question, in most of the Indian dialysis centers, they don't want to keep a line for even for the positive room also. If the negative line is going, the RO looping is going for the negative room, they don't want to continue for the positive rooms. They say that negative room will have the separate loop, positive room will have a separate loop. It doesn't mean that we want to separate the lines and all for patients and all. Like there is no connection between the positive patient and the negative patient if you are connecting the loops and all. So you can have a single loop for all the missions, whether it is a negative mission or positive mission, no problem at all. Coming to the in-depth about this question about the storage tank, that storage tank, it is always better to go with the peracetic acid disinfection compared to any other disinfectant.
Right. I think that covers most of the questions. Pradeep has raised his hand. Bhupesh, if you would allow him to unmute himself and ask the question, I think that can be the last question for the day. We've already crossed 1 o'clock.
I given him the right for unmute. Pradeep, you can unmute yourself now.
Yeah, hi, I'm Dr. Pradeep from Rajahmundry, Andhra Pradesh. So it was a good talk from Tyagarajan, but one of my question was left out. One is regarding the parasitic acid. Like the parasitic acid you recommended, it's good compared to the bleach disinfection, that is sodium hypochlorite disinfection for the storage tank and the loops. So my question is, like, if we go ahead with the parasitic acid, what will be the dose and what will be the contact time? And second thing is, do we need to do any check level after doing the disinfection, or we can straight away go ahead with the dialysis after the disinfection?
Actually,
Because with the bleach, we never do any check after that, right? We just do the disinfection and then we can straight away go ahead with the dialysis. But with the parasitic acid, is there any recommendation? That too with the PVC pipelines, medical PVC pipeline, I mean loop lines. Yeah.
Good question.
Yeah, actually, when you are doing a parasitic acid disinfection, we generally keep it for a minimum for 3 to 4 hours as a contact time for the loopings and everything. And I can share you the documents based on your, if you can tell me your tank capacity and the loop capacity, then there will be a little bit of a variation is there. So you can send me a mail across to me, sir. Because whenever we do, because customizing the looping is most important. Sometimes the loops are coming from 8th floor to the 2nd floor. Some loops are very near, some floors are same floors. So sometimes I need to understand the loop dimension. So I can send you the exact timing and everything. Because there is a calculation for that. I can send you those details. Sir.
Okay. Can you share your email ID for that?
Yes, sir. I will share my email ID here over the, you can see that from the screen itself. Sir.
Okay. So do we need to check any level, or we can just after the contact time is
we have a parasitic acid strips are available. And then we can check it out what is the concentration level of a parasitic acid in the water level. So that it is possible. We can do it in that sense. So I will send you that what is the concentration we want to use it. So it will be easy also. So this is my email ID, tides.ceo@gmail.com. So you can send me your tank capacity and your length of your internal diameter and length of the tubing by your plumber, sir. So they may give you the exact volume. So based on that, I can able to calculate the volume and I can tell you how many hours it is required for you. Generally, it is a 3 to 4 hours we'll do, but it depends upon your capacity. We will give you the right suggestion for your.
Okay. So one more thing is, are there any kits to do on-site endotoxin level? You mentioned about on-site endotoxin level.
Yes, sir. There are kits are available for the online endotoxin level. This is by the different companies are there in India. Generally, I never take any one company name. There are more than 4 companies are there, or international companies are available. What I found is there should be a good association between all the hospitals to do this test, because the cost of the kit is itself it's more than because there are 2 methods. 2 methods are there, which is a bigger one is automated and semi-automated are there. So we can go with the side on-site also. It is possible.
Okay.
Yeah, there are many companies are there. 4 companies are there. I can share you all those details.
Fine. Thank you. Thank you so much.
Thank you.
If there are no further questions, can we end the session today? 1:12 now.
Yeah.
Thanks so much to Dr. Tyagarajan for giving this talk. And thank you to all of you for attending on Sunday.
Thank you. Thank you very much.